to Digital Health Talks, where we spotlight healthcare leaders driving measurable change through technology. I'm Megan Antonelli, CEO of Health Impact Live, and today we are tackling one of healthcare's most critical challenges, scaling AI for real clinical impact. Our guest, Dr. Deepti Pandita, VP of Clinical Informatics and CMIO at UCI Health, and a physician in the Department of Medicine, has achieved what many health systems struggle with: seamless adoption that delivers quantifiable outcomes and increases physician satisfaction and retention. At Orange County's only safety net academic medical center, Dr. Pandita has reduced hospital stays, streamlined workflows, and co-authored national AI policy guidelines. We'll explore her evidence-based playbook for AI ROI, clinical adoption strategies, and addressing digital disparities at scale. Hi, Dr. Pandita. Thanks so much for joining us today. How are you?
I'm very well, Megan. Thank you for having me on your podcast.
Yeah, it's great to have you back. It was such a pleasure and honor to moderate the panel you were on at the HIM SoCal meeting. But tell our audience a little bit about what you do there at UCI and sort of your career trajectory.
Yeah, sure. So, like you said, I first and foremost am a physician. I'm trained in internal medicine, board certified in internal medicine, have been a physician for over 3 decades now. I'm dating myself. But then for the last 2 decades, apart from being an internal medicine physician, I'm also a clinical informaticist. And, I'm what I call an accidental informaticist. I happened to foray into informatics when most organizations were going from paper records to electronic records. And that was my first interest in what is this, intersection of people, process, and technology. And it turns out that I had a natural acumen for it and have been an informaticist for about 2 decades now in various roles. I would also say that I was the first batch of clinical informatics physicians that got board certified. So I'm dual board certified now. And it's been an honor to train the future physician informaticist generation since then. I still am a faculty for training our clinical informatics fellows at UCI Health. So when you ask me what I do at UCI Health, I am sort of have, a leg in each area. So I'm in operations in the IT space as the VP of Clinical Informatics on the health services side, but then I also have a role in the School of Medicine as a faculty for teaching our clinical informatics fellows, and then also as a care provider.
Yeah, it's such an, amazing career, and you've done, such an amazing job, and you're such a great speaker because you have sort of sat on both sides as a physician and as an informaticist, and kind of the implementations that you have done are so impressive. And I think what I love about sort of the informatics discipline is it's such a diverse area that clinicians have gotten into. And I think also women really adopted, kind of went into that space. It was very, in an area that is maybe sometimes not as accessible, that many nurses and physicians were able to kind of get into healthcare technology through that space. And it has a nice balance to it.
Yes, it does.
Yeah.
And I'm glad you brought up the topic of women and informatics, because it is a very natural fit, I think, because, informatics, yes, there is a technology piece, which, there's always that impression that women and tech are sort of not aligned. But the bigger piece in informatics is around usability and implementation science, which is very natural to the female psyche. We understand, the end-to-end picture. We never get bogged down into just the narrow picture. We always look at the big picture. And that's why it's a very natural fit.
Mm-hmm. Yeah, I never thought about that, but it's true. I mean, the analytics piece of it and the really gives you that deeper understanding of the whys, right? We talk a lot about people, purpose, the people, process, and technology, but I think the purpose behind all of it, of what we do, is so important. And that's what informatics kind of aims to answer, right?
Exactly. Yes.
Yeah. So tell us a little bit. I know when we met and on that panel, we talked about AI and the AI implementation, which, of course, is really just the another word for informatics in some ways, right? We've just graduated, but tell us a little bit about what you're doing in that space around, clinical decision-making and ambient documentation. I know that's been something that you guys have done a lot in.
Yeah, so at UCI Health, how we are thinking about AI is AI doesn't need its own strategy. AI is sort of the underpinning of every strategic plan we have. So if you think of AI in that manner, then you will pepper it across all your strategies, plans, no matter what it may be. And then AI sort of catapults that plan in a manner that you didn't think before, in terms of driving efficiency, ROIs, operational gains. So instead of thinking of AI as its own standalone thing, we think about it as more of a horizontal across everything we do. But that being said, when we started our AI governance, and I chair our AI governance at UCI Health, we thought about it as, yes, we need the governance principles around, trust, transparency, reliability, and everything we talk about in the AI realm. But in terms of use cases, we wanted to tackle the high yield, low risk use cases first, before we tackle the high risk, high yield cases. So we looked at the spectrum of where we had those low risk, high yield cases. And the problems that we were trying to solve were all around burnout, workforce efficiency, and then also wellness. So those were the areas that we wanted to focus on. And ambient documentation seemed to rise to the top to address all three. And that's why we were very early adopters in ambient documentation. We actually started in December of 23 when it was just a very, very new tool. And now we have almost everyone in the enterprise using some form of ambient documentation on the physician side. We haven't yet rolled it out on the nursing side, but we do have plans to do that. So ambient documentation is definitely a game changer. I mean, we have so many testimonials from providers telling us, like, I'm able to have dinner with my family, I'm able to leave the clinic on time, or I'm the envy of my peers who are not using it, as, looking at me as being so efficient. Or even things like my patients love it because now they are able to face the patient instead of facing the computer, So really, it has been sort of a very rewarding endeavor. The other big, efficiency gain we have had using AI is responding to patient messages. So people don't understand, as consumers, when they send a message to their provider, of course, you feel that you're the only one in that provider's universe, and you should get the attention. But imagine each provider has a panel of 1,500 to 1,600 patients. And if even 1/4 of them message on any given day, that's a lot of messages. And we started looking at it as, how do we, enhance the efficiency of responding to these messages? And not all messages need like a physician level decision making. So we started looking at AI as to give us context to the messages, which ones need clinical decision versus those that don't. Like if you're just looking for an appointment, or if you're just looking for, what was my last lab results, and things like that, those can be dealt with, in a different manner. And then we started creating draft responses using AI for those messages. And that has been really rewarding because it saves the providers a lot of time because they were having to draft these letters and things like that. So another great efficiency gain in that area. So those are sort of the very low-hanging fruit type use cases.
Yeah, I mean, and that's, I think, both with that, in what you were saying, was sort of that low risk, right? And high. I think about it all the time because I am a messenger and I will message my kids' physicians fairly often, and I think, God, you must get so many of these, but it is, it is efficient and it works. So, and to think, and a lot of it is kind of, okay, what do we need to do to fill out the football form? It's not just, clinical stuff. There's so much administrative stuff that has to do it, that you deal with healthcare. So for sure, to go back to the ambient, tools and using them and the physician response. I mean, I think that it must be so rewarding because there's been so many times over the years where we've implemented technology that has not had a positive response, right? And to know, yes, physicians are perhaps a bit more tech savvy and want that, want the technology now, but for it to be as new as it is and to have such positive responses, that it's doing what it should is exciting to see. Are there specialties that it works best in where you've rolled it out and you've seen it's, better?
Yeah, I mean, obviously, ambient documentation relies on a conversation. So if the patient or the provider is in a position of not having a conversation, it will not work. So think of like an anesthesiologist, it's not going to work. Or patients in the ICU setting, it's not going to work. So those are the scenarios where obviously, you're not going to use a tool like this. But where it is working very efficiently is where most of the visit is conversational. So think of primary care settings like family medicine or internal medicine or pediatrics, where everything is happening in a conversational manner. It's very good at that. Specialties that are more procedural driven, obviously the yield is lower there.
Right.
Because you have to then it's not intuitive to a physician to be narrating a procedure, to the patient. So some have actually adapted to that and are doing it, and then the tool serves them well, but it doesn't work for everyone.
Right. It's more of a documentation, element there as opposed to as a sort of encounter capture. In terms of evaluating, right, when you've got obviously, metrics around clinician and patient satisfaction. But sometimes these wellness or, as we, call it pajama time or the time saved are not something that you automatically are measuring. How are you evaluating kind of the outcomes and the success of some of these programs, particularly when, they're quite expensive? So where does
So we do look at those metrics. So apart from just time savings or, in terms of time saved in actual documentation or time to closing of the encounter, which is also important because that has an ROI. The sooner you close that encounter, you can send it for billing. That means that you're getting the payment more quickly. So, our revenue folks like that aspect of it. So there is that tangible ROI there. But we also measure something called NASA-TLX index, which is the cognitive burden on the provider. And we have seen improvements in that. That indicates that it actually does reduce cognitive burden. We do measure pajama time, and we have shown, improvements in pajama time as well, which is the after hours time, spent in documentation. So yes, we look at it as a holistic tool, not just to drive documentation efficiency, but the actual wellness impact on the provider.
And are you getting any pushback? I know they like it when they have it, but I know certainly in the nursing world, there's a lot of, are we going to be replaced by AI? I mean, I feel like we've been having that conversation about physicians for a long time, but how is that going and how are you addressing that within the organization?
It is a constant conversation, and I think it all starts with education. People have a lot of misconceptions about AI. Is it going to take my job, or is all my personal information getting leaked to some AI tool, or how will it? And this is a very valid concern. Will my voice files now could be used in in a compliance legal sort of case, or even for our learners in the system, they worry that could this be used to have, sort of subordination issues, because they can, look up what I actually said. So a lot of those issues do come up, and we have to reassure everyone that no, that is not the purpose of the tool, and no, the tool is not capturing or being sent to anybody who would then have secondary gains from it. So, and then our legal procurement, other areas are very cognizant of these things. And then They look at the agreements, they look at our, contracts to make sure that these areas are addressed.
Yeah, that it must have a lot of ramifications on that side of things. I mean, it's a similar conversation to what we've been having for years, just around notes, right?
Yes, exactly.
Shared notes and open notes and the concerns there. But in a world now where we're basically constantly recorded all the time, whether we've got the recording on or not, it is a concern. And in a highly litigious environment of risk and all of that, it must, a lot of things to think about. Luckily, those legal teams, their jobs are safe.
Right. And one thing we have been very, very cognizant of at UCI Health is the area of consent. We do not use any ambient tool unless the patient consents. And, California is a two-party consent state. So we not only get the consent for agreeing, we also get the consent for denying, and we document it. Mm-hmm. So that is something we have really educated our providers on, is consent for using AI is very important.
Yeah, no, absolutely. You talked a little bit about, measuring and understanding the kind of cognitive burden and the reduction of cognitive burden for the clinicians. I mean, when it comes to, how that translates into their satisfaction, right? Their retention, their happiness, what are there specific areas that you are looking at to address?
So we partner with an organization called CLASS, and we do an annual wellness survey of our provider community. And some of the questions there are around EHR-related burden, and also around, and we have surrogate measures for, the wellness aspect, which is like intent to leave or intent to reduce work hours and all of that. I'm happy to say that with ambient, we have seen an improvement in those measures in our annual CLASS survey. So there is some directional indicators. It's not statistically significant yet, but directionally, it is suggesting that these tools are helping the wellness aspect of the provider. The one interesting area that's emerging, which we have not embarked on yet, but some other organizations have, is studying the voice files for distress. Provider distress is a big area, especially in nursing. Nursing distress is something that is being talked about more and more. So we hope to study that and see if that is improving, or if there are mitigatory measures we can take if distress is related or picked up in the voice files of the provider.
Right.
There are studies in the behavioral health field where on the patient side, distress in voice can be a surrogate for depression, anxiety, all of that. There is enough publications on that. But we want to apply the same principles on the provider side.
Yeah. And that would be such a sort of advanced way of quantifying their well-being. Exactly. Yes. That would be amazing. So to talk a little bit more about the patients and that satisfaction level, has that been something that you've been able to sort of quantify, other than that? You mentioned that they like it generally, but how is it impacting, those kind of scores?
So patient experience surveys have directionally shown improvement.
Mm-hmm.
Now, we don't ask a question, we partner with an organization to do a patient experience surveys. There's no direct question that did your provider use an ambient scribe tool and did you have a positive, experience? But we have seen that providers who are using ambient seem to have a little bit higher patient experience score than those that are not. Mm-hmm. Now, again, directional, but promising.
Right. Of course. And that's, I think that experience element of, as you said, just more direct face time with the clinician is so important. It's what we've all been saying we wanted for so long. And then it's ultimately, sort of what measures and metrics impact that.
Right. And interestingly, we have so many providers using these tools now. And we have about 80,000 notes now already created using ambient. We have had one patient decline, to consent to use it. One out of like thousands and thousands. So that tells you that patients are very much appreciative of getting the attention from their providers, at any cost. Yeah.
Right. And appreciative of their own clinicians' well-being, right?
Exactly.
I think
Yes.
in some ways, certainly the pandemic made us more aware of and conscious of that,
Yeah.
The stress that is there. So, and that is certainly a good thing. So that's, the low-hanging fruit. These are the first steps. These are the pilots, the programs. What's, as you think about what's next in terms of AI adoption at UCI, what's on the horizon?
Well, two big opportunities. Being an academic center, we want to, be at the cutting edge. So we want to work on our own LLM that is health specific, HIPAA compliant, to drive our own operational efficiency. So that's one. And then the second area we are, eagerly exploring is agentic AI and create, sort of use cases within the operational enterprise using AI agents. So the simplest example would be we created a bot that just scans our knowledge document database for our EMR. And when people are stuck or need help on the spot, they would have to call a helpline or go find a tip sheet. So now with this bot, they can just type in a prompt and it's presented to them. So again, one, it reduces the dependency on humans, but it also is very fast and, just in time. So there is a win on both sides. So that's the sort of agentic AI we are thinking of in terms of very low-hanging fruits. And eventually, there will be a time where there will be, the human out of the loop completely with agents talking to agents, So
Right.
That's sort of the next frontier.
Absolutely. And what are when you think of in terms of just sort of the building of the LLM and even the technology behind that, are there some, sort of resource considerations that are being made?
Oh, absolutely. I mean, one, just the GPU consideration. I mean, you can't stand this up without having, that backbone infrastructure. Two, you need very robust data sources. I mean, yes, the EMR could be one, but for all operational databases, there is HR, there is finance, there is, other third-party systems. So you need sort of a very good enterprise data repository because, again, otherwise it will be garbage in, garbage out. So you do need good backbone on your data structure in order to even think about signing up your own LLM. Yeah.
Yeah, I can imagine. And in terms of the resources needed from that, are you finding that you're having to increase or your IT staff and IT teams, or what's is it net neutral?
So I wouldn't say it's increasing. I think it's shifting skills. So you definitely need roles like data scientists, who are, AI savvy. So that's a new emerging role. And then even so your data analysts who are just used to doing SQL queries and things, you have to upskill them to now think differently. So we are fortunate to be in an educational institution where these resources are available. So I would say we are not hiring net new, except for maybe a data scientist or two, but we are looking to upskill our current workforce to be more AI ready.
Which is, of course, across probably the whole organization as well on
Yes.
the clinician side too. Talk a little bit about, with nurses and physicians, is there sort of upskilling training that is happening to help them better understand? I mean, you said part of this is just education for them to understand. Right. What do some of those programs look like?
So we haven't done any dedicated programs yet. We do have ambitions to create some micro learnings around AI, both for physicians and for nursing. We do have some resources available through our campus that are free and that people can avail of. We do provide a lot of sort of at the elbow support in terms of answering questions, when we are onboarding people for, ambient documentation as an example, or presenting other tools. And then we do have a lot of work groups and committees. So like I said, we have an AI governance committee. It's a multi-stakeholder committee. We have legal, we have ethicists, we have, researchers, all part of that committee. They may not come from a background of AI, but when they sit on that governance council, they ask the questions that a layperson would ask, and then when they get those answers, then they disseminate those to their, peers and colleagues. So it's sort of that each one teach one approach that we are taking. But we do have ambitions to create some micro-learnings on a longitudinal basis, very unique to our own providers and nurses.
Right. Yeah. I mean, and I must, as an academic medical center, the ability to, one, translate those learnings into education and take that, but also that, plus the sort of desire to, do you have in the, sort of research realm and kind of how it's impacting research? I mean, I know even in my, simplistic research, using these tools is amazing. I mean, I get the news and the stories of the week and all of that stuff and be able to synthesize it and create, lots of content. I can't even imagine when you're working on such complex topics as medicine and all of this stuff that these tools are amazing, but then also the dealing with the other side of it, the hallucinations and sort of sorting through the great information and the not so great information is challenging. Are there some guidances around that?
We absolutely, on the research side, we absolutely provide those guidances. We have actually implemented some AI, rules of the road in even our IRB, process. For journal publications, there are definitely some guardrails we have put in place. How we approach it is, telling people use it for the administrative aspects of research. So, for example, a very cool use case is clinical trial matching for patients. So, normally you would need to go through these Excel spreadsheets and look at what trial is available for which patient, for which cancer, all of that. Now with AI, you can automate some of that. So, but that leads to research, but you have really, reduced the time to match that patient to the right trial. So those are the sort of use cases we sort of educate people on. Hey, you can use AI for, saving time in terms of matching patients. But then the actual research, you still have to apply the rigor and the methodology that research requires.
Right. Of course. Yeah. And you talked about kind of how people are, sort of using their own agents, how the organization and you have this sort of drive and desire to build, internal agents. And that, we used to talk a little bit about kind of shadow tech where physicians or clinicians, people would get their own tech and manage that. I mean, now it's, there's this abundance of it. And so in terms of just, is it mostly just kind of governance? These are the guidelines and this is what we're doing, or are there kind of checks as well?
Well, there are checks. So our compliance team is really on top of these things because people can go rogue very easily. And people don't understand that there is a very, fine line you're walking. There is HIPAA still applies, whether you're using AI tools or not. And the perfect example would be when ChatGPT launched, some of our residents started using it to write patient discharge summaries, not understanding that it's not a HIPAA compliant tool, you're leaking PHI, all of that. We got wind of it and had to, educate them, hey, stop, you cannot do this. At the same time, I understood that this was really a question of driving efficiency, and they were liking it because, they would take 2 hours to write one discharge summary, and now it's taking them 10 minutes. So of course they're going to, use it. So again, education was key in that. And then also some auditing, otherwise people can start, going rogue very easily. So yes, so we do have some audits in place, and we also have, the cautionary things around HIPAA and compliance and consent and all of that.
Yeah, no, it is a sort of, it's this brave new world, if you will, in terms of managing, but I have to imagine that from that senior leadership position, it's almost like, plugging holes and
yes,
in a leaky water.
I have spent more time with our compliance and risk folks since AI, became mainstream than I ever did previously.
Sure. No, absolutely. So as you look sort of a few years out into the future of this, and it is moving fast, what do you think, what does it look like? What does the clinical care picture look like for folks in terms of, whether it's from the physician perspective or from the patient perspective?
I think agentic will be sort of very mainstream down the road. And it just won't be, agents that health systems are buying. I think it will be agents that health systems are creating for their own use. That I think is going to be pretty natural and pretty much accepted, across the healthcare care continuum. And a lot of these agents could be patient-facing. They could be, as an example, today, when you log into your patient portal, it's an English-only medium, or could be a couple of other languages. And you can imagine plugging in an agent there where it translates to your preferred language and your reading level and explains everything. I mean, that would be a game changer in terms of patient education. So those are the sort of things that excite me about this, because it's also an impact on health disparities. When you think about using AI to be the equalizer for disparities as opposed to be the divider. So that is something very exciting. The other thing is workforce, problems in terms of we cannot staff up like we need to, especially in the nursing side. So whatever we can do to drive efficiency or retain current workforce is important. So that's the other thing we look at in terms of where can AI play a role, like virtual nursing as an example. That is very prime for every organization where your actual boots on ground nurses do the actual acute care, and then intakes and things like that can be done by virtual nurses. So that's another area that we are excited to look at. And then the third area is most health systems now have they're multi-hospital systems. How can you use AI to scale efficiency across systems? So you see that, I can predict now that this hospital, because of this traffic congestion or this accident happening there, their ER is going to get congested. Can we move people who are still waiting there into another area, or direct them to say, don't go to this ER because this trauma is coming there and you probably won't get seen for 4 hours. You can go to this other center. Mm-hmm. And AI does have very good cognitive computing models to give those insights depending on which parameters you feed. So I think that big, sort of cockpit of providing that insight is going to get very exciting soon.
Yeah, we already used the air. I was going to say it's like air traffic control.
Air traffic control, yes.
From that standpoint, and that I think that would be amazing, is just sort of like bringing up that triage element all the way into the healthcare system as a whole, and what kind of impact that could really have.
And we need to plug in not only just the healthcare into it. We need to plug in weather. We need to plug in ambulance movement, traffic, geography. All that needs to be a data point in that whole spectrum, because then you will really drive efficiency.
Right. No, absolutely. And then that efficiency, answers that equity and access question, because as there's more efficiency and there's more care available, and that it becomes more accessible to people, and then you solve many problems.
Exactly. Yes.
Well, it is a promising new area, and I just thank you for spending time with us today. And if our audience would like to kind of reach out, is LinkedIn a good place to?
Oh, absolutely.
Connect? Yes, absolutely. And I know you speak at a lot of different events and conferences, so and you post there. So I encourage everyone to reach out and attend any that Dr. Pandita is at. Thanks so much to our audience for joining us today. The conversation continues every month at Health Impact Live. Our virtual events are every third Thursday. And thank you so much for being here. This is Megan Antonelli from Digital Health Talk, signing off.